Good morning, everyone, and thank you for joining us today. My name is Melissa Miranda, and I'll be moderating today's session, and I'll be turning it over to a few of my colleagues throughout the hour. But before we get started, I'm going to quickly review a few of the housekeeping items. First and foremost, this webinar will be recorded, and the presentation will be available on our website at www.healthcarefornewengland.org. The actual presentation is available now, and the recording will be available in a few days. The phone lines will be on mute for the duration of this presentation, and we ask that you please do not put your phone line on hold during the webinar. We will use the chat function to receive and answer questions. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. I'm joined by colleagues from each state's QIN-QIO team who will be monitoring and responding to questions and comments in chat. And we will go through the questions and answer them at the end of this webinar. Also, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. But before we get started, we're going to just ask you two polling questions. The first question is, what state are you from? Please let us know if you're from Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, Vermont, or some other state. The next question is, how many people are actually watching this webinar with you? Indicate whether you're by yourself, by one, have 2, 3, 4, 5, or more staff members with you. So it looks like the polling actually popped up for this one, so if you haven't answered yet, go ahead and answer in the polling question and hit submit. Okay. Having this information is actually helpful. There's always some technical issues with webinars and knowing exactly who's participating, so I'm happy to be able to capture this information right off the bat. So it looks like a lot of you are viewing this webinar by yourself, so hopefully the recording and having it available for other staff will be great. During today's session, we'll continue our focus on transitions of care. And so the goal is simple, that New England nursing centers will apply strategies and best practices that will aid in reducing hospital readmissions by 20% or more over the next 5 years. So with that in mind, we'll recap where we left off from March 26th and begin focusing on how QAPI should be embedded in your processes. We'll also talk about healthcare-acquired infections and the use of Advance Directives. It's not our intent to teach you what you already know about these topics. Rather, we want to highlight how they too can impact your hospital readmissions. We also want to provide you with information and educational tools for your staff that support the quality and performance improvement process. We'll close today with a tutorial of how to access any of our material online when you need it. The objectives for today's session are to utilize the expertise and information delivered today to formulate a unique dissemination strategy for your center. We'd also like you to apply this learning by creating awareness throughout your center for staff, family, and residents. To recognize the activities that must be implemented to reduce re-hospitalizations, and finally, to ensure you know where to go to access all of the collaborative material. But before we get started, our regional team would like to recognize you in honor of National Nursing Home Week. It's an exciting time to be a part of healthcare in our country. The direction that we're moving includes person-centered care, more informed consumers, improved practices around care transitions, less invasive treatments and procedures, and an emphasis on wellness and prevention. As our population ages, seniors, caregivers, and families are also changing, and the nursing homes must change too. In fact, many of you are already changing. From the bottom of our hearts, we want to thank you for all that you're doing, and we thank you for taking your time today to be part of this webinar and certainly to be part of our collaborative, for allowing us to support you as you work towards continuous quality and performance improvement. It's because of you, our stakeholders in the Nursing Home Corporation, that 526 nursing homes out of 943 in New England are participating in this regional collaborative. Now, I'm happy to turn this over to Margie McLaughlin, our Consultant Director of Education, who will recap the collaborative work so far. Margie, are you there?
Yes, I am. Thank you, Melissa. Delighted to be with everybody today, and I want to thank you all for joining us. I hope you can feel the excitement in today's call as we begin to really pick up speed and beginning to deliver and bring our collaborative together in a really powerful way. It must feel really good to be part of 526 people throughout New England who are part of this work, and we're delighted. So let's just recap where we've been. Over the last few months, what we've done is gathered our community, and what we did in the process was to actually begin to get folks to sign on to this work and to really begin to think about the strategies that will actually help to reduce re-hospitalizations and to even think even more broadly about how to better the way we do transitions of care. When we got started, we all joined together for our big kickoff call in February, and then later we began to drill down in the March call to actually talk about the ways that we think about reducing re-hospitalizations, improving transitions, but overall, how we're just generally going to take better care of our residents when it comes to these topics. It was so exciting for us to get the feedback that you provided. What we saw was that many of you took a lot of time and a lot of thoughtful consideration and put together some really thoughtful ways that you would go about transferring knowledge to practice. Lots of you wrote us notes and told us in your readiness surveys some of the work you were doing, and I am going to highlight some of those in just a minute. One of the things that's clear, though, throughout this whole process is that the topics that we've chosen from March all the way on through to November all contribute to improving transitions of care. All of these topics were hand-chosen because of the special nature that they have in helping to strengthen our ability to do great. And with a goal that's as lofty as reducing 20%, we really want to give you the best possible tools available. That's why we have experts who are on the call today and will walk you through some of the materials that they themselves have created just especially for you. So we're really excited about that. Let me tell you just a little bit. We got to know you just a little bit more. Lovely things that we heard. We heard from so many of you who talked about that you began to really hone in and think about new ways to provide education. Many of you described the process as kind of old school, bringing people together for an hour and a half at 3 o'clock. And so what we saw in the responses that you gave us were that many of you were really excited about this whole notion of pollination education. And so kudos to you who who read through that introductory welcome book, saw pollination education as one of the strategies. And I heard from folks who said, oh my gosh, I went to my director and immediately started talking about pollination education and how we could make our education on the floor in smaller, easier bites for the folks all around us, particularly our CNAs, making it available to them, finding ways that they could help spread the news. We heard from a couple of folks who had already gone to the trouble to put table tents on their tables in the break room so that people would know and understand that they were part of this collaborative that was attempting to reduce re-hospitalizations by 20%. Another area that I saw that was terrific, I saw so many people talk about how they felt that they wanted to create a much more diverse and robust way of training. And so what they talked about was some people were going to do a hybrid. They were going to be using the computers. They were also going to be out there on the floors trying to help people in the moment to have a better understanding of how they could better support this process, teaching people about when to hospitalize, when to not hospitalize, teaching people about adverse events and the part that we contribute to that. And also, I saw a whole gang of folks who said they wanted to use huddles as part of their education platform, where they just, while people were huddled together, they would use those moments to teach people. So kudos to all of you who were part of those comments. I also noted that a number of people were really motivated after March 26th call. Many people described how they were really motivated to improve their 5-star rating, and they saw this as a great opportunity to use the tools and resources that are supplied by the QIO QIN to help in that process. Let me also share with you one other thing that I just totally loved as I was looking through your comments. Just so you know, don't ever underestimate what you're writing, because we so pick up on that. There's a whole team of us who are looking through those notes. Here's where I said a number of you were really motivated to create action plans around re-hospitalizations. One of the things I wanted to share with you that was time and time again I read that people were thinking ways of including families, and others talked about how they wanted to create a plan that would actually provide an ongoing education program to families around the topics that we're doing right here in the collaborative, so that families would understand when or when not to send people to the hospitals, so families would understand what these adverse events are. Exciting stuff, I got to say. I just also wanted to add, because quite a few of you wrote about engaging families, that one of the tools we're going to make available to you is one that was created by Dr. Ruth Tappan, who's a professor and the Christine E. Lynn Eminent Scholar at the College of Nursing at Florida Atlantic University. She just completed this great guide for families, and it's just been released. It's called Go to the Hospital or Stay Here, a decision guide for patients and families. And I just got to talk with Dr. Tappan just recently, and she's offered to share that with all of you. I think what you'll find in that guide is a great tool that you can use one-on-one with families or do in a resident council or a family council meeting. So really exciting. Those are some of the things we were learning as we got to know you a little better, as we were reading through the comments. What I wanted to share with you is that you're going to hear a lot today about some great educational tools and resources that have been created. If you haven't already done so, go onto the website, because the whole introduction series is there. And so you can access it now, and you can take those education plans and actually begin to put them in motion. What you will notice, though, is that many of those modules were actually created what we call before and after thinking. And so this is what I want to challenge you with right here, right now. Before and after thinking is the kind of thinking that goes like this. Before the module, before the training, we used to do things like this. But now now that we've gone through and now that we know more or know something different, now after we've done this training, something different is going to happen in our organization. So my challenge to you is to adopt before and after thinking. As many of the people who will be doing the training who are right here on the call with me, think about what it is that's going to be the after part. So do the training, and then what's going to happen after? How are you going to get it out to people? How are you going to share? How are you going to make it exciting? How are you going to really energize your place around that particular topic? So before and after thinking is kind of key. If you scoot over to the next slide, I think I've shared a little bit about some of the highlights from the community, some of the things that you're doing. We look so forward to sharing more about those. So please share with your state, your affiliate, and share some of those interesting stories with them. Don't hesitate to write those things to us. We have a great call planned for you today. I can't tell you how excited we are. We're going to go over some of the ways that you implement QAPI into your work. We're going to talk a lot about, we're going to hear from a really well-versed team from the University of Massachusetts who, the folks are going to walk you through some of the healthcare planning sections. You're going to hear about the positive effects of the Advance Directives, and we're going to walk you through the website. So, all exciting things, and keep up the great work. We love hearing from you. And Melissa, I'm going to pass that back off to you.
Thank you so much, Margie. We've been learning a lot from the folks who have completed the readiness surveys, and so we appreciate and thank you all who have done that. And if you haven't done that, it's a great way to capture what you've done so far, and so you can find that on our website as well. We'll probably put that link right into the chat for you. But with no further ado, I'd like to introduce you all to Sarah Durenick. Sarah oversees the Nursing Home Quality Care Collaborative in Massachusetts, and her background is in nursing home administration. Today, she's going to overview the QAPI piece of our work and how it relates to your care transitions work. Sarah? Thank you, Melissa. Again, if you completed the readiness survey, you should have received a link to access the first learning module. If you have not yet completed this, we will provide in the chat a link to the survey. You are also asked to complete the online self-assessment, and many of you are well on your way with incorporating QAPI within your improvement efforts. The first module includes 3 learning sessions on how to embed QAPI in your transition process. The learning sessions focus on 3 areas: a background on QAPI to help you determine if your current quality program meets QAPI principles, how to put into action the 5 QAPI elements and help get you started in developing your quality charter, and framing your performance improvement project. We will walk you through a real example and show you how easy it is to outline a PIP. During these learning sessions, you will hear about the QAPI program charter and PIP outline forms that we created to help you develop your facility's written QAPI program. Also, there are QAPI notebook sections to help guide you. We've heard from the staff of several nursing facilities who are already using these, and when asked by surveyors what they are doing to incorporate QAPI in their improvement efforts, they were more than impressed with what they had to show them. We also spoke with the State Survey Agency Director in Massachusetts, who encouraged using these to be proactive before CMS officially comes out with the regs. The QAPI program packet can be downloaded for use from our website. We are asking that when you complete your charter and outline your PIPs, that you share them with us. We want to know what your goals are. That way we can provide you with additional materials and tools to help your PIP teams. If you've identified additional opportunities for education, we can refer you to various evidence-based programs that are available, including programs that may be offered within your state. Using PDF-based cycles to implement your charter and PIP, you will be able to develop your aim statement, what it is that you want to actually accomplish. You will determine how to measure and evaluate your performance in order to know if you are improving. and identify what changes need to be made in order to improve. The National Nursing Home Quality Care Collaborative Change Package, which was updated in March of this year, offers various strategies, change concepts, and specific actionable items that high-performing nursing homes have used that resulted in improvement. Remember, your QAPI program is always a work in progress. It changes as the quality needs within your Also, the PIC focus should be on short-term, measurable goals within a specific time frame. By focusing on short-term goals, the team is more likely to experience improvements quickly and will encourage them to continue their improvement efforts. Don't forget to send your charter and tip outlines to your state lead and feel free to ask any questions that you may have. We look forward to celebrating your achievements with you. Thank you for your time today. For the next segment, I'll turn it over to Dr. Jerry Gerwitz, Chief in the Division of Geriatric Medicine at UMass Medical School. Dr. Gerwitz?
Hi, everyone. I just want to make sure everybody can hear me.
We sure can. Thank you.
Great. So, thank you. My name is Jerry Gerwitz, and I lead the Division of Geriatric Medicine at the University of Massachusetts Medical School. And it's really an honor and a privilege to be able to participate in this collaborative. Today we'll be focusing on reducing healthcare-acquired infections, and we'll be, during this webinar, introducing two important concepts to you. These include antimicrobial stewardship and infection control. Next slide. So I would like to introduce my colleagues who will be sharing a presentation with me today. Dr. Catherine DeBow is Clinical Chief of the Division of Geriatric Medicine at UMass Medical School. And Kathleen Mazur is Professor of Medicine in the Division of Geriatric Medicine at the University of Massachusetts Medical School. So you'll be hearing from them shortly. Next slide. So what are healthcare-acquired infections, or HAIs? And I'll be using those two terms interchangeably throughout the presentation. HAIs are infections that people acquire while they are in a healthcare facility, like a hospital or a nursing home. They can be caused by bacteria, fungi, or viruses. Risk factors for HAIs include use of indwelling urinary catheters, injection, contamination of the healthcare environment, transmission of communicable diseases between residents and nursing home staff, and importantly, overuse or improper use of antibiotics. Next slide. So why do HAIs fit into this collaborative on improving the quality and safety of care for nursing home residents? Well, healthcare-acquired infections are a serious threat to our residents. They're really common. 1 to 3 million serious infections occur every year in the nursing home setting. They're deadly. As many as 380,000 patients die of infections they acquire in the nursing home setting. And they're very, very costly. Infections are among the most common reasons nursing home residents are admitted to the hospital. And that's why HAIs are so important as we work to address safety issues relevant to transitions in care. And that's both from the hospital to the nursing home and the nursing home to the hospital. Next slide. There are two major approaches for reducing HAIs. The first is antimicrobial stewardship, which is making sure antibiotics are appropriately prescribed. When inadequate attention is given to antimicrobial stewardship, antibiotics may be overused, leading to antibiotic resistance. Overuse of antibiotics also increases the risk of C. diff infections, which are well known to all of you. And we all know what a challenging and difficult problem that is both for short-term rehab patients who come from the hospital and for our long-term care residents. The second approach used to reduce the risk of healthcare-acquired infection is infection control. Infection control helps prevent the spread of existing infection and therefore protects residents who are especially vulnerable to infection and also protects nursing home staff. Next slide. Okay, protecting HAIs is a win-win for everyone. We'll be looking at opportunities for quick successes, and that's always important for our staff as well as our residents. Reducing HAIs takes teamwork. It can't fall on one person's shoulders to do everything. And there are important opportunities for all levels of staff to participate in meaningful ways. We're going to provide you with an abundance of resources with some great opportunities for sharing and learning. Addressing HAIs also can reduce the risk of preventable hospitalization. And that's an incredibly important goal for this entire initiative, as has been emphasized already. The bottom line is that by reducing HAIs, we make our nursing homes safer for both our residents and our staff. Next slide. The Hatch model is a tool used by many nursing homes around the country to help maintain their focus on quality. Hatch has 6 domains and can be applied to any quality improvement project. In this case, consider how you would apply Hatch to antimicrobial stewardship and infection control. For instance, what workplace practices would you need to have in place to enhance antimicrobial stewardship? What in the environment needs to be improved? What care practices need to be in place? And how about leadership? What must the leaders be doing and modeling for others? In the area of family and community, how do we engage them? And stakeholders, and that includes government and regulatory organizations and agencies. What must be addressed in this domain? This approach helps nursing homes to look at their improvement work through the 6 domains of Hatch. Next slide. So now that we've emphasized the importance and opportunities in reducing healthcare-acquired infection, let's introduce part 1 of this module, antimicrobial stewardship. We will discuss the definition of antimicrobial stewardship, why it's so important, and we'll discuss the role and responsibility of our nursing homes to make sure antibiotics are appropriately prescribed. Next slide. What does antimicrobial stewardship mean? The definition of stewardship is the careful and responsible management of something entrusted to one's care. As healthcare providers, we are entrusted with the careful and responsible management of antibiotics. From the moment we assess a resident for an infection to administering a prescribed antibiotic. Antibiotics demand our stewardship because antibiotics are the only drug where the use in one resident can impact the effectiveness in another, and that's due to the development of resistant bacteria that can spread from one resident to another. And often that is due to poor hand washing, as we'll mention in a few minutes. If everyone does not use antibiotics well, we all suffer. Next slide. We misuse antibiotics in a variety of ways. Antibiotics are given when they are not needed. They are continued for too long when they are no longer necessary. Or often, they are given at the wrong dose. We also sometimes use broad-spectrum antibiotics to treat infections that would respond to simpler, more targeted, narrow-spectrum antibiotics. Next slide. Antibiotics are misused and can result in an infection called C. diff. C. diff is a bacteria that lives in the gut that is normally kept in check by many good bacteria that normally live there. Many commonly used antibiotics can wipe out the good bacteria, leaving C. diff to take over. And C. diff makes a toxin that causes diarrhea, which can be very severe. C. diff causes 500,000 infections yearly, and the nursing home setting presents a perfect storm for C. diff, because the main risk factors for this infection are antibiotics, older age, and living in a nursing home. C. diff infections are strongly associated with antibiotic use. Up to 85% of patients who develop C. diff have been given an antibiotic in the preceding month. C. diff is truly a deadly diarrhea that causes severe illness. 1 out of 11 patients age 65 or older who get C. diff die within a month. Next slide. Another important consequence of antibiotic misuse is multi-drug resistant organisms, and I'll refer to those as MIDROs. MIDROs are superbugs that are resistant to many commonly used antibiotics. So familiar examples of MIDROs are MRSA, or methicillin-resistant Staph aureus, which can cause serious skin and other infections. Another is VRE, or vancomycin-resistant enterococci, which can cause UTIs and other infections. Treating multi-drug-resistant organisms is extremely challenging. Common infections such as UTIs that are usually treated with oral antibiotics may require intravenous antibiotics. The cause is a MIDRO. And MIDROs may only be sensitive to very special, very expensive antibiotics, which can be hard to obtain. And that presents their own challenges. Next, I'd like to introduce Dr. Kathleen Mazur, who's going to present the next topic.
Great, thank you. So now that we've convinced you of the importance of antimicrobial stewardship, how do you put it into action? Remember, antimicrobial stewardship means making sure antibiotics are appropriately prescribed. To do this, we need to start with asking 4 questions. First, is it the right time? That is an antibiotic really necessary in a particular situation? Next, is it the right drug? Will the antibiotic cover the likely or presumed bug that the resident has? Is it the right dose? Not too high, given the resident's other problems, such as kidney disease? And finally, is it the right duration? Is the length of treatment more than is really necessary? For example, many UTIs need only 3 to 5 days of treatment, not 7 to 10 days, and the more a resident is exposed to an antibiotic, the greater the chance of developing resistance. Next slide. So now, before we move on to introducing the lessons for Part 1 of this module, we'd like to ask you about antimicrobial stewardship at your facility. The polling question here is, do you monitor whether bacteria found in positive cultures in your residents are resistant to common antibiotics? The options are yes, no, or not sure. Please start the polling question. And so, will we see some results?
We will. So the poll has ended. It'll just take a few seconds and the results will pop up.
Super, thank you. Oh, great. So, I'm sorry. So that's great. So actually a fairly high percentage of you do. So that's very interesting. We appreciate your sharing that. If we go to the next slide, this is a question actually that only applies to those of you who said yes to the last question. And the question is, if yes, that is, if you do monitor whether bacteria are resistant, does your nursing staff know the rate of resistant organisms to different antibiotics, or know where to find that out? Again, here the options are yes, no, and not sure. And if you answered no to the prior question or not sure, go ahead and skip this. Don't so you need to respond. So please start the polling question.
So when you're completing a polling question, don't forget to hit submit at the bottom of the screen.
Great, thank you. So it looks like of those of you who answered, the majority do or aren't sure whether their nursing staff know the rate to different organisms, so the rate of resistant organisms to different antibiotics. So that's very interesting. Thank you for sharing that with us. We're going to go to the 5 core elements of an antibiotic stewardship program. And what are the core elements of an effective program? Well, first, commitment of senior leadership. This is very important in setting the emphasis here. Accountability. There needs to be a responsible point person. There needs to be appropriate expertise. That is, often the involvement of a pharmacist can be critical. Action. There needs to be policies, guidelines, and an ability to intervene and to assess the impact of the intervention. And finally, tracking, reporting, and providing feedback are also essential core elements. Next slide, please. We've designed 3 lessons for the first part of this module on antimicrobial stewardship. Lesson 1 is Antimicrobial Stewardship 12 Steps. It emphasizes the CDC's 12 steps to prevent antimicrobial resistance among long-term care residents. Lesson 2 gives the principles of preventing antimicrobial resistance, and it includes the correct diagnosis of UTIs. And Lesson 3 focuses on treatment of UTIs and encouraging best practices using SBAR. Next slide. So this slide depicts an example of an antibiogram. I'm not sure how many of you have already seen these, but an antibiogram is the result of laboratory testing for the sensitivity of an isolated bacteria to different antibiotic choices in your facility. This can be a great tool for your facility, and we mention it because you can learn more about it in Lesson 1. Now I'd like to introduce my colleague, Dr. Catherine DeBow. She's going to start on Part 2, which is the next slide, please.
Thank you, Kathy. Can everyone hear me okay?
We can, thank you.
Okay. Now we're going to go to Part 2 of this learning module on improving infection control. Under this general topic, we'll consider the following. First, prevention of the spread of infections with a focus on preventing transmission, particularly through hand washing. Second, we'll talk about urinary catheter use and management, because as we mentioned before, devices can be an important source of infection in the long-term care setting. Third, we'll talk about proper methods of catheter insertion, again to reduce the chance of infection. And finally, we'll also talk about protective gear and precautions. Next slide. So what are the components of infection control in the nursing home setting? In the nursing home setting, there are many infections that can be easily spread in this environment, if infection control isn't done optimally. We are going to focus on three main aspects of infection control for long-term care. These are hand washing, personal protective gear and precautions, and proper use and maintenance of urethral catheters. Next slide. Next slide, please. First, let's discuss hand washing. There is much in the scientific as well as popular literature on how lack of hand washing is the root of much evil. You probably do not remember this, but all of Dorothy's problems in The Wizard of Oz began because Auntie M did not wash her hands after going to the outhouse. You can see in this excerpt, one day after returning from the outhouse, Auntie M forgot to wash her hands, which caused a bacterial infection to spread among the whole family, including the dog. In addition to severe stomach cramps and a dreadful fever, Dorothy started to have some really strange dreams. Next slide. Hand washing is the single most important topic we are introducing today. Washing hands prevents illness and the spread of infections to others. This is important because hands are very important sources of the spread of germs. Hands get germs from touching the eyes, nose, and mouth, and also from touching contaminated objects in the environment. These include tables, handrails, clothing, and stethoscopes. Germs spread by hands can cause respiratory infections and diarrhea, including C. diff. And hand washing with soap or sanitizer removes germs from hands when done appropriately. In regard to hand washing, I want to give a special plug to the hand hygiene video in Lesson 4, produced by the New England Journal of Medicine. This video is excellent for staff, is accessible, and even entertaining. Next slide. The second aspect of infection control is the use of personal protective gear and precautions. Personal protective gear or equipment are things we use to protect ourselves from getting and spreading germs from persons or residents with infection. These include standard items like gloves, gowns, masks, and eye shields. Precautions are standard procedures to prevent infection. In addition to universal precautions, these include things such as resident placement. That is, identifying those residents with infections who should be in a single room or grouped in a room with other residents with the same infection. This can also mean isolating residents who are at high risk of acquiring an infection. Contact precautions, that is, avoiding direct skin contact with residents with certain infections. Environmental cleaning, these are procedures the facility uses to ensure that all areas of resident care and common areas are appropriately cleaned. And handling of soiled materials, that is, how potentially contaminated materials, ranging from clothing and bedding to soiled gloves and dressings, are disposed of. Next slide. The third important topic regarding infection control in nursing homes is urinary catheters. Infections can occur any time a device is placed and kept in the body, and any device kept in the body can become a site for infection. Residents who have urinary catheters have a high risk of catheter-associated urinary tract infection, or QAPI. This is because 100% of residents with catheters develop bacteria in their urine by 30 days. This means that every resident with a long-term catheter has bacteria in their urine and runs the risk of this bacteria causing an infection. Next slide. We have a polling question here. How many residents with urinary catheters do you have in your facility? The potential answers are 1 to 5, 6 to 10, or more than 10? Please start the polling question.
I don't see the polling question popping up, so let's just give it a couple more seconds.
Okay, let's see what we have for prevalence of catheters. All right, so it looks like among people on the call, there are relatively few catheters in your home. Most people, it looks, have 1 to 5. There's a few more with 6 to 10. This is an important thing, and one we'll focus on in later modules and lessons, is that even though you may have few residents with catheters, these few residents present multiple opportunities for infection and spreading infection. Next slide, please. This is another polling question. Do you specifically track CAUTI in your facility? And the answers are yes, no, or not sure. Please begin the polling question. We should have the answer very soon. Okay, so it does look like most people do track CAUTI, which is terrific. So I'm going to turn the speaker over to Dr. Zerwitz again.
Thank you, Catherine. So one thing that Catherine emphasized is that we want to underscore that by focusing on urinary catheters, even though they may be few, they can still have a very positive impact on the 5-star rating. Urinary catheters, even the few, have a lot of implications. As you all know, inappropriate use of catheters to manage incontinence is poor quality of care. Catheters can lead to UTIs, as we all know. And in addition, something we don't always focus on is that catheters can impact in a variety of other ways. Some have referred to catheters as single-point restraint, and thus they can have an impact on the activities of daily living, on ambulation, and place residents at increased risk for falls and also pressure ulcers. Next slide. In regard to Part 2 of this module on infection control, there are 4 lessons that will be available to you. Lesson 4 is entitled Wash Your Hands. You'll look at a variety of hand washing resources and look at strategies to improve proper hand washing by all staff. We can't emphasize enough how important that is. 60% of the time, staff do not wash their hands after caring for residents. Lesson 5, appropriate catheter management. What are the established consensus guidelines on proper catheter management, and how do they compare with your policy? Lesson 6, care practices for correct catheter insertion. One of the things we found in our own research is that despite required training, many nursing home staff do not follow proper techniques when inserting catheters. Each improper insertion, whether for changing of chronic Foley or obtaining a urine specimen, is an extra chance for infection. And lastly, lesson 7, understanding protective gear and precautions. Who needs to use what, where, and when? So we commend these lessons to you very, very highly. Next slide. So we're wrapping up our presentation now with your next steps, which are the following. First, engage infection control and education staff to help lead your efforts. Review the presentation that we made today, as well as the lessons with your staff. And begin to implement the lessons 1 through 7 in your facilities. Next slide. So thank you very much, and we'll transition to the next presentation.
Thank you, Dr. Gerwitz and team. Next, and I know we're getting close to the time, but we have 2 more quick presentations. I'd love to introduce you to Nelia Silva Odom. Nelia is going to talk about the importance of Advance Directives in reducing hospital readmissions. Nelia is leading the Nursing Home Quality Care Collaborative in Rhode Island. So I'm turning it over to you.
Thank you, Melissa. I'd like to start by having you ask yourself, who would make medical decisions for you? How would you choose to live and be cared for? Have you ever documented this? These are all questions to keep in mind when having the advanced care planning conversation. Next, we'd like to start first by debunking a few common myths. It's very important to remember that none of these are true. The first myth is that advanced care planning is a discussion about dying. It's an understandable misconception, but in reality, advanced care planning has very little to do with dying. In reality, it's about making sure you're able to live the way you want to live and receive the care you want to receive in a situation when you may not be able to tell people what you want. Your life may be near its end, but it may also be a long way off. The second myth is that completing an advanced care plan is expensive to do. Everything we're going to be talking about today is 100% free. You don't need to hire a lawyer or an expert. Third, advanced care planning is about pulling the plug. Not true at all. In fact, at times, it can be exactly the opposite. Advanced care planning is about telling people what you want. Some may want everything possible, all measures, while others may not. Neither choice is wrong, and advanced care planning doesn't push one over the other. Following up on the last point, the next common myth is that advanced care planning is only for people who are terminally ill. While it's true that advanced care planning will not be used unless these types of decisions need to be made and the person cannot make them for themselves at that time, no one should wait to prepare. You can always change your mind. What is it really? Let's talk a little bit about the living will. This is a very important aspect of advanced care planning. The living will is a written document where you specify your wishes for care in various situations. It gives doctors, caregivers, and family members instructions for how someone would want to be cared for if unable to say so for themselves. It's very detailed. It covers various situations. such as an end of life and wanting to be hospitalized, or whether to remain at home. This is a legal document. It's official. Doctors are required to adhere to it. When discussing advanced care planning, it is crucial that all staff are involved. The physician must have the conversation, but all staff members must be able to understand and able to discuss what choices were made and follow through despite own thoughts and feelings. Having the conversation. This may be the most important aspect of advanced care planning. If and when the time comes when medical wishes need to be known, we want to make sure that everyone is on the same page. This includes family, friends, doctors, caregivers, and whomever else may be involved. This is important for several reasons. First and foremost, you don't want there to be any confusion. People have different opinions on things like this, and every opinion is okay. If you don't discuss advanced care planning, you can never be certain of what those you are taking care of want. You can't just assume. It's important to make sure that all are on the same page. It's also important because medical decisions can be difficult. In some cases, the decision is harder than others. But having choices made clear and understood is of utmost importance. What's the plan? Ensuring that a comprehensive care plan that does not overlook a thorough advanced care plan is key to following wishes. Present person-centered scenarios. An elder may have congestive heart failure or CVA. By individualizing advanced care planning, in some cases, this will avoid readmissions. The conversation will have occurred with the elder, family, and care team, and making certain that the plan of care they would like to receive is adhered to. The conversation, as I mentioned, is one of the most important aspects. If and when the time comes for medical wishes to be known, we want to make sure that everyone is on the same page. This includes family, friends, doctors, caregivers, and whomever else may be involved. It's important for several reasons. We do not want there to be any confusion. People have different opinions, and every opinion is okay. If it's not discussed, however, caregivers can never be certain of what wishes are voiced. Caregivers will know exactly what choices were made and not assume. Family and friends may also have different opinions between them. Either way, it's important to make sure that everyone is on the same page. It's also important because medical decisions can be difficult. In some cases, the decision is much harder than others. There are many informative resources available to assist you in your advanced care planning conversations, such as the My Care, My Choice, My Voice. We have several resources available for you on the Healthcare for New England website. Used together, they will bring increased awareness and open the door to have the advanced care planning discussion and assist in decreasing readmissions because wishes are known. We have an informational half sheet, wallet card, and poster. Additional materials will be posted as time goes on. In addition to the resources, there is a widget that can be found on the site where you can display the My Care, My Choice, My Voice on your website and be linked to the materials from there. Where can you find the materials? Here on the Healthcare for New England website. We also have resources that will assist you when you're having your advanced care planning conversations. And as mentioned, they will have an impact on your readmissions. Next, I would like to introduce Alex Bronk. Alex is a member of our communications team. Alex's background is in digital media and graphic design. She is manning our website and ensures the educational materials are available to you for 24-hour access. Today, she will spend a few minutes reviewing the website to help you better access the information.
Hi, everyone. Thank you. I'm Alex Gronk, and I want to talk to you about the website. This is healthcarefornewengland.org, and this will be your home base for you to find all the information you will need. This zoomed in red is our main navigation, and from left to right you will see home, about us, get local for providers, information for everyone, events, careers, and contact us. We understand websites can be overwhelming, so we wanted to give a quick tutorial about how to find information that's related just to nursing homes. So on our main navigation, you're going to hover your mouse over the For Providers link. A drop-down menu will appear, and you will move your mouse down and click the nursing home menu item. This is the nursing home page on the healthcarefornewengland.org website. On this page is a set of tabs that has different information depending on what you'd be looking for. Information on upcoming webinars and events, educational modules, peer coach facilities training, Faces of QI campaign information, resources and past events information, and contact information. One tab in particular that I wanted to focus on is the educational modules. Here you will see a Series 1 tab. Inside it is the Module 1 spoiler. If you click it, it will expand and show hidden information. In here is the Part 1 and Part 2, which we have been speaking about throughout the presentation. All of this will include PowerPoint presentations and recorded webinars. As future modules are released, different tools will be given to you to help you throughout your transitions process. The other thing I wanted to review with you is our email. We understand how emails can be overwhelming, so we wanted to go through just our layout of it to help make the process easier. Highlighted in red is the title of the email, which is usually the webinar name or important information. On the right-hand side, highlighted in purple, is the body of the email. This will include a brief description and a registration link. On the left-hand side is usually the facts about the webinar, which is usually where and when the webinar will take place. The most important we saved for last is our to-do list, which will be links to the recently released educational modules or any surveys that you and your team need to complete. Thank you. Great. Okay, I know folks are running out of time here, but I just want to just highlight this last slide, which is, the types of things that you can be doing between now and July 9th, which is our next webinar. So we'd like you to ensure that your quality teams are identified and begin meeting. You can actually, from the website, access the Series 1 guide. There's plenty of information in there about how to get your team started and the types of things you should be doing. We'd also like to remind you to complete the readiness survey if you haven't already. And then you can begin to review and use the learning modules. The learning modules will be released over the next few weeks, and you don't have to review and use them in any specific order. However, Learning Module 1 is a great place to start because it includes all the specific startup steps that are related to the QAPI process. And so Learning Module is available now. But for all the others, you'll see Learning Modules 2, 3, 4, and so on. There's actually 9 learning modules in this series. Those you can do in any order that you'd like. And certainly we'd ask that you contact your QIN-QIO team if you need any help. We are out of time for our Q&A session, so I'd like to suggest that if you have questions, to submit them to your state teams. I'll have their contact information here. There have been no questions submitted through the chat, so I'm going to keep moving forward. And I just want to thank you all for joining us today and ask that you take a couple of minutes to complete the webinar evaluation that will be available to you at the close of this webinar, and you'll probably receive through an email as well. Today's session will be posted on our website with a recording, and that will be available in a few business days. We thank you again for attending. Have a great day.